Hello friends, I am Dr. Harsh Mathur from Om Netralaya, Varanasi, India. This video contains an operative procedure meant for eye surgeons for education purposes. Viewer discretion is strongly recommended, and today I will be talking about how to go about a supracapsular phaco in cases of a very soft cataract grade 1 to 2. So there are various ways to deal with a soft cataract. You can go about doing a direct chop, but then holding the nucleus is a big problem. Stop and chop, making a trench, we can easily go and hit the posterior capsule and divide and conquer. Breaking the nucleus is a big task. So we should find a way which is repeatable and which can be easily managed. So what I feel is, while dealing with these soft cataracts, it's best to bring these soft cataracts out of the bag and then do a supracapsular phaco. So now a triplanar incision is being constructed, barely nicking the limbal vessels, with a 2.8 millimeter steel keratome. The incision is made. Another side port is constructed, and now is the time to make a rhexis. So this is a mid dilated pupil, and as you can see by making this mark, it's approximately 5.5 to 6 millimeter dilated. In order to do a supracapsular phaco and tumble this soft nucleus out of the bag, a generous 5.5 mm of rhexis should be created. And to do that, hydrodissection is very important. At first, a gentle amount of fluid is injected, and now a continuous flow of fluid is injected behind the lens, and this lens prolapses out of the bag. And now is the time to go in with the phaco probe, trying to buzzing in the center of the nucleus and trying to divide the nucleus, but it is so soft that it's cheese wiring. But still I have got a reasonable 2 halves, and now with minimal amount of phaco energy and mostly vacuum, the piece is slowly engulfed. Care should be taken to always stay in the central safe zone and not to get too close to the endothelium. So I am trying to work at the level of the iris plane, and you can see the second instrument is doing all the hard work, bringing the nuclear pieces in front of the phaco probe, and in no time the soft nucleus disappears. So playing with this nucleus in the bag is a bit risky. There are chances of fish bowling of the nucleus, as well as while chopping there is cheese wiring, there is difficulty to hold the soft nucleus. So this technique I feel is easier and repeatable. And if you use high viscosity (1%, 1.4 or 1.8% hyaluronate to protect the endothelium), then it's even safer. So wound assisted IOL implantation is done. The leading haptic goes in the bag, and the trailing haptic is gently dialed in. A thorough visco wash is then done to avoid any post-operative spikes, IOP spikes. It's always better to go behind the IOL and remove all the visco in the bag. And that's it. Now is the time to close the incision. So the take home message is, do what is best in your hands and what is best for your patient. And do a surgery that is repeatable and that you can easily manage. So the lens is now well centered in the bag. The anterior chamber is cleaned thoroughly with the viscoelastic substance, and the wounds are closed. I hope you like this video. Do like and subscribe and follow for more such interesting videos. Thanks for watching.